Welcome to this explainer on the massive GINA 2026 updates. We are looking at a literal paradigm shift in how we manage asthma. For patients 6 and older, if you treat asthma, you absolutely have to know about this change. You know, for decades, we've all instinctively reached for that classic blue inhaler for rescue. It's just baked into asthma management, right? But the new data forces us to ask a pretty uncomfortable question. Is SABA-alone therapy actually endangering our patients? Let's look at why SABA-alone fails. We all know asthma is fundamentally an inflammatory disease. So think about it. If we just treat the bronchospasm with a short-acting beta agonist, we're leaving that dangerous underlying inflammation completely unchecked. We're literally only treating half the disease. And it turns out regular use of SABA by itself isn't just ineffective, it is actively risky. The data shows it sets off this terrible domino effect. It increases eosinophilic airway inflammation, which then reduces bronchodilator responsiveness, and ultimately, that drives higher rates of severe exacerbations and even mortality. Because of all that, the GINA 2026 guidelines have drawn a definitive line in the sand. SABA alone is no longer recommended as rescue therapy, period. That applies to anyone aged 6 and up. Which brings us to the new AIR paradigm. AIR stands for anti-inflammatory reliever therapy. The core concept here is super simple, but completely revolutionary for our daily practice. Every single reliever strategy must now include an inhaled corticosteroid. We have to treat the inflammation at the exact same time we relieve the symptoms. So for your patients, you basically have 2 options to make this happen. The strongly preferred route is using ICS formoterol for both maintenance and rescue. Now, the alternative, if that preferred method just isn't feasible, is to make absolutely sure the patient takes an ICS whenever a SABA is used. Let's zoom in on that preferred strategy, known as SMART. That's single inhaler maintenance and reliever therapy. It's a real game changer because it uses just one ICS formoterol inhaler to pull double duty, acting as both the daily controller and the rapid symptom reliever. The clinical outcomes of the SMART approach are seriously impressive. Having just one inhaler naturally boosts patient adherence, right? Which means we see a massive reduction in severe exacerbations and ER visits. And crucially, especially for pediatricians out there, it safely decreases exposure to systemic corticosteroids. Let's talk about dosing by clinical severity. When rescue therapy is needed, the dosing actually scales really intuitively based on severity. Mild symptoms, just 1 puff. Moderate, 2 puffs. And if they're in severe distress, you step right up to 2 puffs, and you can repeat that every 3 to 5 minutes while you continuously assess the patient. Now, there is a crucial guardrail to remember here, and that's the daily limits. For adolescents and adults using budesonide formoterol, the hard cap is 12 total puffs a day. For children aged 6 to 11, that max is 8 puffs per day. If you're managing an acute ER setting, you can administer up to 6 puffs in that first hour. But the real magic happens at discharge. You want to make sure you step these patients down by continuing SMART as both their maintenance and reliever therapy. Maintaining that continuity drastically reduces their risk of bouncing right back to the hospital. Let's wrap up with the key takeaways for your practice. The absolute most crucial takeaway from all this is simply this. If a patient's symptoms are severe enough to need a reliever, their airway inflammation is significant enough to require immediate anti-inflammatory treatment. We are officially closing the chapter on just treating the bronchospasm. The data is totally clear and the guidelines are set in stone now. Using an ICS is an absolutely essential component of rescue therapy.